Welcome to our podcast, Psychiatric Services from Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa. Happy summer.
Thank you. It is summer. Just started. I love these long days. Today, we're going to talk about 3 articles from the journal that have recently been published online. We're going to take an inside look at use of outpatient and inpatient services by individuals with a diagnosis of autism. We're going to look at the impact of AOT without ACT, or AOT, assisted outpatient treatment, and ACT, assertive community treatment, and how they connect or don't. And finally, we're going to be talking about something a bit controversial in behavioral economics, that is paying people to take medicine.
Should be a good episode.
I hope so.
First up, we have David Mandel and colleagues on the effect of outpatient service utilization on hospitalizations and emergency visits among youths with autism spectrum disorder. Got that?
I think I do, although you started saying the title like 10 minutes ago.
So, basically, if you have people use more outpatient services, it's going to help decrease emergency visits and hospitalizations.
Okay, yeah, that makes sense.
Yeah, well, I'll have a second career as a title writer for psychiatric services. So this article really piqued my interest because in my day job, I'm working a lot on systems issues around treatment of people with intellectual and developmental disabilities in our public mental health system, in our emergency rooms and patient settings. And I've just seen the tremendous gaps in services that we have for the population. So I was very interested to see an article in Psych Services that was starting to address some of these gaps.
Yeah, I see autism as an increasingly important public health challenge. And I remember when I tweeted on a previous article in Psych Services, I wrote that I couldn't remember a single lecture or discussion or care conference on autism during my residency, which now it could be that I have a bad memory, which I probably do, but I do think it reflects a bit on the fact that in general psychiatry, for sure, we have a knowledge gap and a knowledge deficit about this disorder.
Yeah, and your sense of it as an increasing public health issue is also in the context of an increasing prevalence of autism spectrum disorder. It was 1 in 150 in 2004 and then 1 in 59 in 2014. So I think that's probably a whole other podcast episode just about
But that's a lot. That is a big increase.
It's a lot. And then I think it's no surprise to people who work in emergency behavioral health settings that they can be high utilizers of those intensive services. So 10% of youths with autism spectrum disorder are hospitalized before they're 21. And kids with autism spectrum have 9 times the psych ED use as those who don't. Mm-hmm. So it sort of stands to reason that if people are using more services in the community, you're going to decrease their use of acute services. But there's not that much high quality research to actually say that this is the case. And you're smiling, so I assume you.
Well, we would love to think that use of outpatient services reduces use of inpatient services, but one could easily argue that more outpatient services might call attention to problems, could also be not therapeutic. So I think that the reason I was, of course, smiling was because the question, answering the question is very important, and that we can't make the assumption that the more we do on the outside, the less inpatient is needed. So we really, that's why it's a good study.
So here's what they did. They looked at 5 years of commercial insurance claims from 2008 to 2012 from just above 100,000 kids and young adults 21 and under with autism spectrum disorder to see if increased use of outpatient services was associated with decreased use of psychiatric ED visits and psychiatric hospitalizations. So they used a database that collected claims from 3 large insurers, and to make sure their data wasn't skewed by high spending outliers, they took out the highest 0.1% of spenders. Mm-hmm. So when they're trying to determine what visits are autism spectrum related and what aren't, they're using ICD-9 codes basically to see if the psychiatric emergency room visit, the psychiatric hospitalization, or the outpatient services were related to the person's autism spectrum disorder. And just to get a sense, outpatient services include PTOT, speech, diagnostic assessments, case management, skills and behavioral modification, personal aids, family therapy, really wide range of outpatient
it's
services.
impressive. The array of services that youngsters with autism might need is pretty extensive.
So one of their ideas is that there might actually be an increased use of these services just in the period of time preceding an emergency department visit or psychiatric hospitalization. But this might not kind of be the whole picture, right? So if you're just looking at the time around, then you might be capturing like crisis visits, and those might go up, but there might be a different story if you look back a little bit longer.
Right. So I think the point and the what's really, I think, powerful about this study is that it does not just look at the use of outpatient services immediately prior to a hospitalization, where there might be a crisis that has sort of already taken shape and have caused the need for more outpatient services, but what they are doing is looking further back in time.
Yeah, and specifically what they do is they divide the time period into 3 separate chunks. So the 2 weeks prior to a psychiatric ED visit or hospitalization, the 3 to 6 weeks prior, and the 7 to 14 weeks prior. So looking at outpatient spending in those different time periods to see how it's related to use of the acute services. So they're also controlling for non-ASD related outpatient service use, psychotropic medication use, gender, age, insurance type, state of origin, and also they have a time variable in there as well. So when they look at their whole sample of this about 100,000 kids, the mean age at baseline was 8.5 years old, and 80% of the sample was male. So over the course of the study period, 9% had a hospitalization and 14% had an ED visit.
Right. And so those 9% and 14% become the sample to be used in the subsequent analyses on hospitalization and ED use.
Right. And so when you start looking at the spending, they have a nice graph actually of spending prior to one of these events. And what you see when you look at it is that spending is pretty flat for the 5 to 6 weeks prior to the visit. And then it starts increasing and spikes at about 2 weeks prior. So like you were saying, they're looking at people who are hospitalized and people who visited an ED. When they look at the people who are hospitalized and they look at the spending, increased outpatient spending in the 2-week time period and the 3 to 6 week time period was associated with increased inpatient hospital use. But in the 7 to 14 weeks, you see an inverse relationship. So increased spending as an outpatient on outpatient services is associated with lower rates of inpatient hospital use. So when they look at people who went to an emergency department, they found a similar trend, but no association between spending and ED visits in the 7 to 14 week period.
One of the notable aspects of the findings are that the reduction was small. It was a small effect when we looked at the relationship between use of community-based services and inpatient use, or the reduction inpatient use with the outpatient services. So it wasn't like a gangbusters, humongo impact. There was a 2% reduction in hospitalizations with the outpatient services.
So I guess the question is, what do we kind of take from a study like this? I think in some senses you could say, okay, so we should increase spending on outpatient services for people with autism spectrum disorder, but not expect that in a crisis it might be different, or does the study really raise some more questions for further research?
Well, I think it would be a mistake, and the authors point this out, to make the assumption based on this study that every youngster with autism spectrum disorder should have increased use of outpatient home and community-based services. This study only looked at kids who are hospitalized, and it looked, and so you can't necessarily generalize this beyond. And I think they argue in some sense for really careful thought about who should have increased services and at what time point, because the study is actually kind of narrow in that regard.
They also point out in their limitation sections that they don't know anything about like, for example, the severity. They don't have a lot of information about what's going on clinically with these
Yeah,
kids.
in fact, the diagnoses, as they point out, were not made clinically. They're just using claims diagnoses from the charts. So we don't have confirmation of the actual diagnosis. We don't have information on the use of school-based or other services that were not included in the claims. They were not able to look at quality of care. And in terms of the medications, they were only able to look at medication use in the week prior to hospitalization. But all those limitations notwithstanding, I think the study powerfully suggests that there may be ways that we can learn and do follow-up studies to reduce the use of what really has to be traumatic inpatient hospitalization for these young people. And I think this really demands further study to understand how outpatient services address the risk and need for inpatients so that we can really use outpatient services in that regard more effectively.
Next up, we have Mark Munetz and colleagues on the association between hospitalization and delivery of assisted outpatient treatment with and without assertive community treatment.
So we are just jumping right into the community here.
Yes,
right?
It's our community day here.
Yeah.
I have to say that as a field, our acronym selection to decrease confusion is really not very good. So we have AOT and ACT here, and they both have the word treatment in them. They both sound kind of alike. So just so that we can dispel any confusion between our two A acronyms, assisted outpatient treatment is AOT. And that's court-mandated outpatient treatment, or as the authors put it, civil commitment of individuals with mental illness to outpatient treatment. So when I think about AOT, I think about somebody who's kind of repeatedly decompensating in the community because they're not taking their medication, they're not going to clinic. And then in states with AOT, the court can say, you have to participate in outpatient treatment, and they lay out the terms for that treatment plan and the consequences for not following it. So AOT is widespread. It's in 46 states and DC, and it's been shown to decrease hospitalization use under certain circumstances.
Yeah. And again, I think these kinds of models are difficult to study rigorously, just end up with these weird biases, and so that not everyone agrees that AOT is effective, but
or ethically appropriate too. It's a controversial program.
Yes,
I think.
It can be.
But it is widespread, and there's a lot of variation between the amount that it's used between states across the country and how the programs work. So, but that's a nutshell about AOT. Our other A acronym is ACT, which I'm going to let you talk about because you were I
was an ACT doc for many years. Yeah, I was a physician on the first assertive community treatment team that was focused specifically as part of research on reducing homelessness. So ACT is a robust evidence-based practice that has been found over the years to reduce hospitalizations and to reduce homelessness. The original conceptualization of it was a hospital without walls. It was a team-based model in the community. The team would include a team leader, a psychiatric prescriber or professional, social worker, nurses, and other modalities. Sometimes now ACT teams include substance use treatment specialists. Sometimes they include family specialists. Sometimes they include employment specialists. And the idea is that they go in the community to where the patient is and try to provide services in the most person-centered way possible. And it's kind of related to, as we think about AOT, ACT, ACT, again, was built for the individuals who in some sense are least served by the traditional system, who had repeated hospitalizations, who were really had trouble staying in the community with only the supports of usual care.
So the important thing for this study is also that ACT is highly intensive.
Right.
It's a very intensive intervention where people are being visited multiple times a month by team members.
In the community.
Yeah. ACT and AOT are related because in some states when you get a court-mandated AOT order, you're required to be on an ACT team or some other sort of intensive case management. But as the authors are pointing out here, nobody's actually studied whether or not AOT is more successful when they include an ACT team versus when they don't. So this study is looking at one particular AOT program in Summit County, Ohio, which is the greater Akron area, to look at this question. And the interesting thing about the AOT program in Summit County is that it doesn't mandate people to be on ACT teams. Some people get assigned an ACT team, others get assigned case management, and that's a clinical decision that's being made as to who gets what. So some people are getting this more intensive ACT services. Some people are getting a little bit, still intensive, but a little bit less intensive case management. And the idea of the study is, does it make a difference which one you receive? Mm-hmm. So what they did is they looked at people who were participating in AOT and wanted to see if they had decreased hospitalizations, and then whether or not this changed based on whether people had ACT or this less intensive case management. So they looked at 8 years of data from 2000 to 2007, and they only looked at people who had been on an order for 6 months or more.
So an AOT order.
Yes, Thank you. So this created a sample of 74 people, 29 were assigned an ACT team, 45 had other case management services assigned. So they looked at the number of days per year that these people were hospitalized before, during, and then after the AOT order.
And so just to make sure that this is clear, these individuals weren't randomly assigned to ACT or not. The judgment was made as to whether the individual in some way needed the more intensive assertive community treatment or not. So they were assigned based on some sense of what the individual needed.
Yeah, and that's really important to keep in mind when thinking about the results of the what they found, so that we're not kind of over-interpreting what they said.
So Josh, what did they find?
So I think the first interesting thing is that whether or not you're on ACT or case management, you got pretty intensive case management services. So I think that the people in case management got something like 10 units versus 24 units for people on ACT. So both were intensive.
And got attention.
Yes, that's right. And so as they expected, the number of days and number of hospitalizations decreased during the AOT order and after the AOT order for the whole sample.
So it went from, the number of hospitalizations went from 3.4 before to 1.5 during and 2.1 after.
So when they looked at whether or not being on ACT versus case management made a difference in the decrease in hospitalizations, they found that during the AOT order, the group without ACT had an average of 1.1 hospitalizations per year, while the group with ACT had an average of 2.3.
Right. And I mean, that's a tricky comparison to make because we know they're not the same, because the individuals who received ACT were assigned to ACT because they had greater needs. So comparing the group with case management directly to the group with ACT is maybe not as informative, but the results are consistent with what you would expect, given that the individuals who were assigned to ACT clearly had more severe problems.
Yeah, and with that caveat in mind, they also found some similar results for after the AOT order was over, where the group without ACT had 9 days of hospitalization per year compared with 23 days of hospitalization for the group that did have ACT.
Right. And so, again, you don't want to make the mistake of thinking, oh, well, that just means ACT didn't do its job. It just means that we had different populations.
Right, and so that's why it's really important to sort of keep that in mind as you're thinking through the results, because the point of the study is not that people do worse with ACT. That is not at all what the study is. It's really just saying that there are people who can benefit from AOT without the more intensive ACT services.
Exactly, and I think that is really the take-home point, particularly given the fact that many communities don't really have ACT services available or readily available, and assertive community treatment is costly. And in some sense, again, we want to supply people with the minimum intrusiveness of treatment in their lives. And so I think this study clearly shows that there is some subpopulation of people who are assigned to AOT who can do well on AOT without the intensive services of assertive community treatment.
And I guess the corollary, though, is that there are probably people who do need more intensive services to do well on an AOT.
That's a really good point, that we see the difference between the individuals who received assertive community treatment and those who didn't. And so, this we're not talking about in our discourse here whether we think AOT is the right way to go or not. It is a part of our system of care, and I think what we would like to be able to do is to deploy it wisely and successfully.
Last up, we have use of behavioral economics to improve medication adherence in severe mental illness from Daniel Guinart and John Kane.
Well, we are going from the frying pan into the fire on this one.
So, at least I don't know if you know what my selection process is for for which articles I choose, but it's generally a skim of the titles, and this one looked really interesting.
It is interesting.
It's very interesting. I think that we should, first of all, mention that this is not a research article. It's an open forum.
Which is a scholarly essay.
It's a scholarly essay, but, I think maybe you can say a word about what the spirit of the open forum is.
Yeah, I mean, yes, I'm happy to do so. So the open forum is really putting forth a set of arguments for dialogue. And just the title, open forum, it's an opportunity for people to discuss a situation or a problem or a challenge and do it in a scholarly, thoughtful fashion. But it's not a research article per se. And I think viewed in that light, this article really does do its job. It asks us to ask questions about certain potential practices.
And it encourages discussion.
Yes.
So, as I was perusing the titles, I saw behavioral economics, and I was very interested in this because I read, I think as probably some of our listeners did, Thinking Fast and Slow, which covers a lot of ground about behavioral economics. Thought it was a great read and really thought-provoking in terms of how it could potentially be applied to our field. And for those who haven't read it or familiar with it, I think the very basics, or that more standard economics, are based on this idea of like people are walking around as rational decision makers. They're going to take into account all of the benefits and the harms, and they're going to weigh them out and
be rational.
And whichever one tips the scales the most, then that's what they're going to decide. But unfortunately, it doesn't seem like that's really the case. Most of our decisions aren't rational at all. And so this field of behavioral economics is trying to make some sense of this by showing what cognitive biases we have that we're just subject to as humans. So here, the authors are interested in medication adherence and how insights from behavioral economics might give us some insights into how to address it.
Or specifically, how to address non-adherence.
That's right. So just to give people a sense, the cognitive bias, this sort of irrational thing that people do that they're identifying here, is present bias. That's sort of our tendency to discount future benefits when we're faced with a challenge in the present. So just an example from my recent past, a physician who likely knows better for the long-term consequences of like binging on sugar might go on vacation and then eat all sorts of foods that they know to be unhealthy in the long run. But they do it anyways because the food is really good. Right. Just, hypothetically.
So did you have some good breakfasts?
I had some amazing breakfasts and lunches and dinners and snacks and all sorts of things. But this is something that everybody does, right? We all make decisions that we kind of know are going to be harmful in the future, but we just like really want that cookie or that cigarette or that whatever. So the idea is whether or not we can do something to balance that bias out. Anybody knows about contingency management for substance use disorder or is familiar with this approach. So somebody who's in recovery might get money or a lotto ticket if they remain abstinent.
Right, so they get an immediate benefit for the behavior that's being supported.
Yeah, and so this open forum is asking whether a similar approach to contingency management might be beneficial in encouraging medication adherence for people with serious mental illness. I think we should mention that there's kind of implicit in this idea that not taking medications is somehow an irrational decision, which I think that a lot of readers will not agree with.
Yeah. Also, that it's at least been very significantly questioned that actually not taking medication might be a rational decision for a variety of reasons, depending on the person. So we know that there's science about the effectiveness of antipsychotics, and we know that there's data about the effectiveness of antipsychotic medications on remission and relapse. But we also know that there's certainly many challenges to some of those data, and we also know that there are some very, very good reasons why people don't like to take antipsychotic medications, not the least of which is the whole array of side effects that it causes. Right. So it's a little more complex than just stopping a behavior like substance use. Right.
But I think the open forum is operating under the assumption that for some people, being on a long-acting injectable or an antipsychotic or another medication for serious mental illness is going to be beneficial in the long run, and that not taking it is harmful. So they do a brief literature review. There's not that much out here, and they point to 2 randomized controlled trials from the UK and the Netherlands where people got cash for getting a depot antipsychotic injection. So both showed improved adherence in the group that received the incentive. So we should say, though, that clinical outcomes didn't actually, and I believe rates of hospitalization or service utilization didn't actually improve in those studies.
So I wanted to make the point, Josh, that the 2 RCTs were really very good studies and done by very, very highly respected groups and investigative teams. So they really demand a read and a look at if you're interested in this topic.
Yeah, and then the authors of the open forum are saying that more research is needed for non-depot medications, non-antipsychotic drugs, and then also exploring the types of incentives that people are using. And then they also bring up a lot of the ethics. It's not just a question about whether or not taking medications or not taking medications is rational. It's also about if you're paying somebody to take a medication, what are the ethical concerns with that, particularly for people who are under socioeconomic stressors?
Yeah, so how is it, and the authors really, they get right to it. The use of financial incentives raises ethical concerns. When implementing the strategy, measures must be taken to ensure that patients are consenting freely and not out of pure financial need. And I think that's a very, very important point, probably easier to say than to pull off, because how can you? What is the threshold when an amount of money itself becomes sort of really helping somebody just eat? And how do we understand that? So it really is quite tricky.
And so it's a tricky topic with some potential gains and then some real concerns on a number of fronts. But I think it's a really interesting read and very thought provoking.
Yeah, I agree, and I hope everybody does take a look at it. And I think it's also an important article because it really does focus us on a number of the challenges and controversies in our field in terms of the use of medications. And ultimately, and I'm just going to say this because I love dialogue, what we really want to do is to help people have the best outcomes that they can. And I think at least I personally am open to creative strategies to do that. But again, it has to be done carefully and thoughtfully, and really with all voices at the table. Well, that's it for today. That was fun.
Yeah.
A lot of thinking, a lot of thought-provokingness. We had a lot of thought-provoking activities this morning. Well, we invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. We remind you to check out the Editor's Choice topic collections available now. Sign up at appi.org/ETOCS, appi.org/ETOCS. The most recent Editor's Choice selection is on disparities. It's really good. And with the Editor's Choice collections, most of the articles are actually open access because they're over a year old. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk to you next time.